All right, good afternoon, everyone. Welcome to the next segment of our Health Center Medical Legal Partnership, or MLP Planning, Implementation, and Practice Webinar Series. You may hear us refer to it in shorthand or abbreviated as the MLP PIP Webinar Series. We are now at conversation number 2. What staff do we need to meet the needs we've identified and accomplish our goals? Today's date is February 15th, 2024, and the time on the East Coast is 1 p.m. Welcome, everyone. I'll go through some housekeeping, let everyone know what our learning objectives are, and then who you'll hear from as our lead faculty for this entire webinar series, and then you'll learn a little bit more about how to continue to join us at future events. So first, the basic housekeeping. As you know, you've joined us on Zoom, and everyone has been automatically muted, but this is a really interactive webinar series. So at some points, we'll actually prompt you to utilize the chat to engage as well as unmute, and we'll provide instructions on how to do that. But at any point, let us know if you have a question. Use the Q&A pane. You can also use the chat to submit a question. To activate captions, select live transcript and show subtitle. And yes, the answer is yes, this webinar will be recorded. It's being recorded right now, and it will be shared on NCMLP's website, medical-legalpartnership.org/resources. We'll make sure we also follow everyone that registered to ensure they have information about where those recordings are being posted. As noted in the previous slide, this is a very interactive webinar series, and at some points we will actually ask you to raise hand to unmute. So there's a raise hand feature in Zoom, and when you use the control bar in Zoom, you may have to actually click on the more button to be able to get that raise hand feature to show up, but you raise hand at the prompts and we'll unmute to hear from you. And of course, again, we'll also utilize the chat to engage. This webinar is supported by HRSA. The National Center for Medical Legal Partnership is a national training and technical assistance partner. And through this grant, we're able to support health centers in particular with their implementation of and utilization of MLP strategies to address the health harming legal needs of their patient populations. Everyone is welcome. Of course, legal services teams are welcome to join, and other healthcare partners. Thank you for joining us again today. This is a webinar series that's running from February through June of this year. And we're partnering at the National Center for Medical Legal Partnership with Texas A&M University's Institute for Healthcare Access. Again, the target audience is health centers, and through this webinar series that's based on the Health Center MLP Toolkit, we're hoping that we can help people better understand how to use that toolkit to plan, implement, and actually conduct MLP practices. Again, it's active learning, so please get ready to engage. All right, as people continue to join, because we know that although it's a small group, folks are coming from all over during the middle of the day to join us. We want to run a poll. So Reha is online from the National Center team, and we'll open up the poll so we can find out who's able to join us today. All right, so for the first question, and Reha, let me know if you want me to hit launch. All right, so folks are filling out the poll. First question is, what type of organization are you from? Healthcare, legal services, or other? Next question is, does your organization have a medical legal partnership? And we know some folks might be joining today and they're not quite sure. And we hope everyone has an answer to the third question. Are you looking forward to the weekend? Yes, of course, duh, because of course. All right. Let's see, we're about 83% participation. So let's go ahead and close the poll and share the results. So we have about 30, this is interesting. So about a third of you are actually joining us from healthcare. Another third of you are joining us from legal services. And then the other third, it's really interesting, almost even split, are joining us from another category. Especially for the folks from the other category, if you don't mind, take a moment to begin engaging with us. Let us know using the chat where you're from if you fell in that other category. Also, interestingly, we have almost a 50-50 split. About half of you said yes, a little bit more than half of you are from the have an MLP, excuse me, and then the other 47% of you do not have a medical legal partnership. So we certainly hope that through this event, we hope those of you who said no will be able to say yes. At least you're on a path to implementing a medical legal partnership. And everyone's looking forward to the weekend, just everyone, of course. So thank you for engaging for that icebreaker, everyone. All right, so let's get started. This is the entire layout of our planning, implementation, and practice webinar series. And we're again at conversation 2, where if you're following along with our Health Center MLP toolkit, you'll know that this is described as a section on how many lawyers do we need to meet the needs that we identified and accomplish our goals versus what we call the event today, what staff do we need to meet those needs and accomplish our goals. Today's learning objectives are as follows. First, we're hoping that this audience, we deliberately, by the way, keep this small. We'll actually unmute, type, chat to help share how you are finally able to identify the legal interventions that a medical legal partnership legal team can take to address social determinants of health. We are hoping that everyone by the end of this webinar will be able to compare some best practices in assessing MLP activities with your current staffing across the board, across all disciplines. And then finally, we're hoping that by the end of this webinar, you'll be able to better examine the P in MLP. I know we usually talk about the M, medical, L, legal, but we're really going to talk about the partnership, right? And then the roles of the individuals across the various disciplines and in actually meeting those health harming legal needs of the patients that are being served. All right, you've been hearing me talk. My name is Bethany Hamilton, Director of the National Center for Medical Legal Partnership based at the George Washington University. And you'll also hear from Keegan Warren, who's the Executive Director of Texas A&M's new Institute for Healthcare Access. And we want to actually introduce you to our newest member of the lead faculty team, Jay Siklick, who's Adjunct Professor of Law at UConn and former MLP Director from the Connecticut Pediatric MLP. So again, welcome to the audience as well as to our lead faculty, Keegan and Jay. You'll be hearing from them in a moment. Also, Reha Manikandasamy, our data scientist on the NCMLP team, is online. If throughout the webinar series you have any questions, please feel free to email Reha at our general email inbox, ncmlp@gwu.edu. She's our senior research assistant and data scientist, but absolutely always happy to help folks find a resource, even if it's the recording or the archives from this event. So speaking of, this again is session 2. We want to make sure folks who may not have joined us or need a little recap since it's been a couple of weeks know what we covered during session 1. So on session 1, that corresponded with conversation 1 of the Health Center MLP Toolkit. We held this event on February 1st, where we, by the end of the webinar, helped folks identify the benefits of partnering with lawyers to be able to help health center patients. We helped everyone better recognize MLP as an effective strategy for achieving health center excellence. And then we hope by the end of the webinar, everyone is able to perform some of those initial steps of being able to determine which SDOH approach you might take through your health center-based MLP. If you'll recall, we talked a little bit about the quintuple aim and how MLP aligns or helps health centers address health equity, improve the patient experience, certainly improve population health and reduce costs, or improve the well-being of the care team by helping everyone practice at the top of their licenses. And this also corresponded with HRSA's Advancing Health Center Excellence Framework. And we talked about how MLP falls into several of the excellent aims related to population health and social determinants of health. And then through the interactive portion of the event, Keegan Warren walked us through some exercises to help everyone better understand how to actually identify or determine which social determinants of health needs to address and what sorts of tools one might utilize, such as examining their EHR data, conducting a needs assessment, and then linking that to the legal interventions, legal assistance, trainings that can be conducted for the workforce, clinic level changes, as well as the upstream policy change strategies that result in systemic change. So today, what we're really trying to drill down on is better ascertaining some of what we know people are asking. One of the key first questions that folks often ask when you approach someone about starting a medical legal partnership, especially if you're in the healthcare, is in healthcare, you might ask, well, how many patients can a full-time lawyer treat? Because in healthcare, you're often doing exactly this when you're determining what workforce you need on the healthcare side to treat patients. So we want to acknowledge that is a question that healthcare will ask, especially for those of you who said you come from the lawyer side of the MLP equation. Be ready for this question to be asked. However, for those asking this question, just know you're going to get the lawyer response. It depends. It depends. And that's not a bad response at all, right? This really depends on need, capacity, resources. There's no clean formula for value-based care. That formula is still being developed. And we do view medical legal partnership as it is a healthcare delivery model as one way to get to value-based care. And that's still being defined. So how many patients can one full-time lawyer treat? It really depends. And we're hoping as Keegan and Jay walk through the next set of content, you'll understand what we mean by it depends. All right, so let's keep going a little bit deeper into what Keegan and Jay are going to talk about in just a moment here. There are several factors that go into determining how many lawyers you need, or what can one lawyer address for patient population, depending on what social needs you selected. Remember, there are a lot of different types of legal needs that patients might be facing. So a patient might require assistance from a lawyer on the MLP for several issues that they have. Maybe there's a family law focused MLP and their child support or custody issues. Perhaps even it's not just like a divorce issue, right? There are myriad issues that can be addressed for one patient, or maybe the legal need is really specific for that medical legal partnership, and you decided to focus on just addressing evictions, right? That also falls within a broader housing legal needs bucket. The team and how it's composed and its resources on the legal side also varies from site to site. Not just lawyers that are involved in the L in MLP, you also have law clerks, paralegals, law students. And so they're from community to community. This will vary depending on, again, capacity, needs, and resources in that community. We also have volunteer lawyers that help to build out capacity on the legal services side. And then the other factor to think about when you're assessing the capacity of a lawyer to treat patients through your MLP is time. So the different types of legal issues that a patient may have may not require full representation. And Jay and Keegan are going to talk a little bit more about what that is versus legal advice. So there are different ways that you can help a patient as a lawyer or the legal team. And depending on how you assist that patient with a specific service, it may result in a different allotment or allocation of time. So you have different types of needs, different compositions of the teams and the resources, and then different time allocations when you think about a lawyer's capacity within an MLP to deliver services to a patient. And you can see a chart on the right-hand side of the screen. This chart is just a snapshot of what we have in more detail in our Health Center MLP toolkit. And we'll be walking through these in just a moment to explain what these MLP activities actually mean and how give you a sense of how the time allocation has been estimated in the right-hand column of the chart. All right, so as I warned everyone, this is supposed to be interactive. Again, we've deliberately kept this webinar series small so that we can get everyone to engage. And so everyone better get ready. Keegan and Jay are getting ready to present. And what Keegan's going to be doing, and Jay as well, is they're going to walk through each of these MLP activities. And then we're going to pause to invite one person from the audience to share an example. We certainly may have time for more than one person to share examples. Then what we'll also do is ask everyone to utilize the chat. Everyone's going to be asked the following question: who on the healthcare team are key staff related to that MLP service? And then finally, we'll ask another person to unmute to please share what's needed from each of those key staff as it pertains to that particular MLP activity that we're describing. So with that, and Reha and I will be in the chat to assist with the engagement. I'm now going to pass things along to Keegan and Jay. Keegan, all yours.
Thank you so much, Bethany. As we've kind of seen in the chat, there's and we saw in the poll, there's a variety of folks here. We're going to start each bit of this conversation with the lawyer, only because it's our experience after many years of helping MLPs get started and evaluate the services that they're providing, that's often the big unanswered question, right? Is what is it that a lawyer can do? And this makes sense if you think about starting. This is not necessarily how we think of our work as lawyers, and yet for healthcare, it's a natural first question. I really want to lift up this idea, though, that Bethany gave us, that we don't have clear definitions necessarily in healthcare either. And so I think we have to have a certain amount of comfort with some ambiguity and with some ranges here. Nonetheless, so we'll start with the lawyers, and then I want us to talk also about staffing in terms of healthcare, right? MLP is a partnership. It's not legal services. So what is the difference? How do we work together to multiply our capacity to make our MLPs have greater impact, and then to know that we're being successful in terms of services? So today's conversation is going to lead in, or it's going to feed other conversations we're going to have later about budgeting, about metrics, about evaluation, sustainability, all of these ideas. So we're going to start with thinking through professional relationships. So this first slide that you're looking at is thinking about the types of MLP services that are in some ways really about the professionals themselves, right? The lawyers, certainly, but also the clinicians. I should say that I think it's fairly typical that when we say clinician, we're talking about physicians, we're talking about nurses, we're talking about social workers, especially clinical social workers, right? So folks who have some professional autonomy and are providing services. So bidirectional training encompasses all of those perspectives. We used to talk, quite frankly, about training I don't know necessarily as bidirectional, but about the learnings for the lawyers and the learnings for the healthcare team. I think what we're increasingly seeing is that this can be a joint effort that puts information together, right? It's not necessarily one or the other. The value here is about building skills, cross-sectoral skills for each professional or each group of professionals, but also about increasing capacity. Because if we ask everyone in their interactions to not think about the ways that the other members of the healthcare team can work with that patient, then we may have missed an opportunity to multiply our own frontline capacity. And of course, this aligns, as you'll see many MLP services do, with core competencies. We've highlighted graduate medical education, but it's worth noting that depending on what profession you're in, you have core competencies, you have skills, and MLP can be very consistent with that, and that includes in terms of training. So I said we were going to start with the lawyers. What is the lawyer's requirement, or what do they need to prep for these trainings? I think it's fairly straightforward, right? We're thinking about time to plan the training. We're thinking about creating deliverables related to the training, whether it's a PowerPoint or whether it's a brief. Very often when lawyers do CLE, continuing legal education, for those who are not in the field, we will do a writing that accompanies it. Of course, you need time to give the training and then to address any follow-up questions. So that our survey, or the survey that was done of the field in several years ago when the toolkit was created, was estimated at 4 to 10 hours for 1 hour training, right? So you're talking about the better part of a day at minimum. For bidirectional training. So the question is, and I can see folks are already starting to answer it, is who are the key staff for each service? And I think the other question here, since I've gotten this out of order, is does anyone have an example they want to share? Any bidirectional training they've done that is particularly meaningful, that had significant outcomes, or that really moved something along for their MLP? Oh, we're a small group today, so feel free to unmute.
And don't forget, use in Zoom the control bar to click the More button. And under the More button, you all should see the raise hand feature. And when you raise hand, we should hear a chime on our end as host of Zoom, so we can unmute you. In the meantime, we'll also look at the chat. And so let us know in the chat if you just want to be unmuted.
Can I just jump in for 1 sec, Keegan?
Mhm.
So I don't want people to underestimate the value of the holistic nature. If we're talking about the professional relationships, and Keegan was stressing the whole is greater than the sum of its parts, but if you look at the top equation in the bidirectional training, the idea of encompassing not just kind of the individual clinical staff who have that direct one-on-one patient relationship in the room, or this is the epitome of including the non-clinical workforce, the frontline staff, that first encounter when someone walks into the health center, and they may not be focused on the 3 things that the MLP team might be focused on, but yet those individuals may be critically important to get that information into the back room, right? So the idea of recognition and awareness from the health center team can't be overestimated. You really have to understand that these trainings, while not everyone is not every training is going to be the same, the opportunity to be as inclusive as possible in these bidirectional interventions is really important. And what it does is it pulls out the social determinants, the health harming legal needs, whatever term you want to use, and it gets it into the forefront because, as everyone in this webinar knows, and all of us, that the significant burden, and it's the old slide that the National Center for Medical Legal Partnership has been using for years, is what is the actual situation that's going on is far greater than what's presented in that 15-minute encounter. And that's the critical nature of the recognition and the ability for that initial encounter and those trainings to bear fruit down the line.
Yeah, absolutely. Right. This is it's not just about the substance, it's also about the process. So we see several people in the chat who are suggesting that this can involve the whole team. And I think that's exactly what Jay was saying as well. I know I have found that sometimes it is that front desk person has the first interactivity with the patient who has great insight for a training. Does anyone have any examples? Jay, do you have an example you want to share?
Yeah, I'd be happy to. Just very briefly. I mean, I was going to talk about this a little bit later, but it's from practice to kind of from practice to the metamorphosis into policy. That's one of the things that, we're going to talk about, down the road. But the idea of recognition of an individual, for example, who may be an adolescent, who may be entitled to confidential care, may be shut out right at the door from the initial stage in terms of the ability to seek care confidentially, when they may have that absolute legal right to do so. And how this morphed in a health center setting was an individual who was seeking a type of care that was potentially confidential, but not certain at the time. And this was an adolescent who was seeking assistance with pre-exposure prophylaxis, or PrEP. And this individual was able to, because of the trainings and because of the encounters that had been already provided at that particular health center, this individual was able to get into the clinical setting and kind of profess to provide the information that then indicated that there needed to be a more significant policy intervention for that particular issue, because it was somewhat uncertain. But it was the awareness and the understanding of the staff and the frontline staff of the health center, folks from the receptionist to the MAs, to all the folks who had an idea that this fell into the possibility that it could be under the umbrella of confidential health care and a legal right that the adolescent possessed. So again, this is a very truncated explanation of something that I could go into a little bit further, but it's the recognition that, you're under a certain age, you're a minor, you don't have the legal right to do this. That may have shut out other folks in other clinical settings, but not in a particular health center that had the benefit of participating in some of these interactive interdisciplinary training and curbside type consults.
Yeah, absolutely, right. That feeds the training. You mentioned curbside consults. Let's talk about those in a little bit greater detail, right? A curbside consult is a type of technical assistance. In the MLP world, we tend to think of this as those water cooler moments where the physician grabs the lawyer or whomever, right? Someone on the kind of traditional healthcare team grabs the lawyer and says, "Hey, what do you think about this? I keep seeing this issue with my patients." It's not about a specific patient. It's not about a specific fact scenario. It's kind of let me pick your brain for just a second. Lawyer, teach me how to respond to these situations, right? Sometimes they're much more formal. And many MLPs, and I think this is a little bit of a food for thought for our lawyers. Many MLPs have formal protocol for that. What do we mean by that? Well, many MLPs will count curbside consults as non-cases, as matters, if you will, in the language of the Legal Services Corporation, which, if you're not a lawyer, is the kind of guiding federal agency for many legal services organizations. And so there's an opportunity to also track this in terms of outputs and in terms of the conversations that are being had. We want to do that for many of the same reasons that we want to engage in training, in bidirectional training, and in partnering in thinking through these ideas, because it builds capacity, it builds skills, and really it can be a mechanism for assisting more patients, because now, for instance, your nurse knows that every time she sees that asthmatic kiddo, for instance, that there may be a habitability issue or whatever, right? And again, it's perfectly consistent with medical education, continuing medical education, continuing nursing education, continuing education units for social workers and the like. Curbside consults can be short. They really can be water cooler moments. They can be, shared lunches in the break room. But they do sometimes result in, I don't know, right? Let me look that up. So now I need to spend some more time doing research. And maybe looking into how we answer this at the institutional level or across an entire population. So 15 minutes to 4 hours is the kind of common time involved as you think about how to calculate these things. So does. Obviously, I think it should be clear that this can also involve the whole team. I think what I'd like to ask is if anyone has any example they'd like to share of a curbside consult that they found meaningful.
Keegan, I want to jump in and see if Sharon Grady, who's joining us today, would be willing to unmute. Sharon, you are able to unmute now if you'd like to tell us a little bit more about what you shared in the chat regarding receptionists and how they engage when folks are checking out to be able to identify legal needs.
Yes, ma'am. So when you go to a clinic and you check out, you come back in 6 months card, our receptionist will be chatting with them, and sometimes they'll mention just in passing, we're going through a divorce, or something that would indicate legal assistance would be helpful. And since we are an integrated model, so our legal staff is actually officed directly in the clinic. They are very aware of us, and they will right then and there create a referral and put them on our intake calendar to be assessed for their legal needs. We're a community center, so we also have a recreation. They do different community events, and sometimes they might identify a legal need. It's not even in a medical setting, so we do it that way. And then for the curbside, I will say one that I found meaningful here is we identified a consistent need of where people die intestate, and it's grandma's house and nobody owns it outright. It's gone through multiple generations. Nobody's paid the taxes. And now you can clear title, but they're going to have, $17,000 tax bill and possibly get foreclosure. So that's a big issue in the community that we serve. And that's something that we've worked with, we've been able to have conversations with the social workers about, because they've seen that need too. And then we've seen that develop on the legal side as well. So we've been able to have kind of generalized conversations about estate planning, and looking to possibly doing some training for the staff in the community for that in the future, because that's a need we were able to identify because of the partnership.
Yeah, how excellent, and how neat to see the intersection, right, of let's talk about what this means, or what the implications here are, right, through that curbside consult, which we can potentially track again, as I mentioned, and let's figure out also how we turn that into a training, not just for staff but also patient facing, and we're going to talk about those as well. I noticed in the chat other people lifting up the idea that the front desk can be really helpful. I think a lot of patients find that to be the most approachable person on the healthcare team. And so it's entirely consistent with my anecdotal experience as well. The other thing, Sharon, that you mentioned is about patient engagement. So let's turn to that idea now. How is it that lawyers engage with patients? I'm not sure that this is always as obvious for non-lawyers. So let's take a moment and kind of walk through this. The first thing that happens, again, kind of turning away from the lawyers for just a second to talk to the healthcare crowd and to talk to our School of Medicine and social work friends, is an intake. This looks very much like the intake that the healthcare system does, but is frankly much more in depth. These are conversations that I would be surprised are ever less than 30 minutes, fewer than 30 minutes. They're very often an hour. They can take 2 hours, particularly because we know that the populations that we're working with statistically have 2 to 3 unmet legal needs. But in any case, this first intake, as it's very commonly called, is about who the person is. Let's gather all that demographic data. And let's put it into our electronic system. So it is in structured data fields, which I think is an important thing to note. And let's talk about what their relevant social history is. Then we can figure out what are the legal needs, might there be legal solutions. The value here is I think fairly obvious. It's how you create that legal care plan. That can take several paths from there. It can turn into advice that is provided on the spot, and maybe later, maybe it's a follow-up. But legal advice or counsel and advice, as we often track it, is about the actual deployment of the legal knowledge base, right? The application of the law to the patient's specific facts. Sometimes this is done in order to enable a patient to represent themselves, what we call being a pro se litigant. Other times it is just to make sure that they understand their rights. It doesn't have to go anywhere from there. There's value in increasing folks' legal literacy. But it may lead to subsequent steps, and we'll talk about those just a moment. I want to pause and ask Margaret, whose hand is poised over the unmute icon, to talk to us about an example, and specifically, can you maybe lift up the role of social work in this process?
Well, I certainly set myself up there, didn't I? Or just blatantly kind of invited myself into the room. So I don't presently work or formally with any MLPs, but that has been my focus and what my learning collaborative is about, more formally including social work. So if you're talking about patient engagement, assessment, that's right off the get-go, that's one of the primary areas I think social work is greatly underutilized. And I base that on much research, not only academic, but in talking with many people at MLPs. I mean, clearly you want to have a very good, thorough, accurate, and in-depth assessment of someone so as to better serve the needs they have. You know, who better than a social worker?
Yeah, absolutely. And social workers probably often also recognize how much time that you're putting in here, right? And not only doing that intake and understanding that person and providing the follow-up. Yeah,
that's a good point you bring up, Keegan, because that's another point is I believe involving social work can make things more streamlined. And, you know, running MLPs, lawyers, you're worth every penny, but are very expensive. So in any way, things can be streamlined and be more efficient. That would be a good thing.
Yeah, can I jump in for 1 sec on that,
please.
Margaret? One of the initial kind of starting back in the ice age of MLP work, literally almost 25 years ago, one of the initial concerns was this idea of, you know, the turfing of responsibilities from lawyers and social workers before MLP was even a thing, before folks like Bethany and Keegan, you know, developed this, you know, incredibly powerful toolkit. Nobody really understood the concept of the roles at that time. And I think even over time, there still has to be this definition until there's this confidence in collaboration, right? And that's the beauty of the nature of having someone embedded and that curbside consult, because nothing can make it clear, I think, almost at the outset as to those roles, as to the definition of the strengths and the power of each individual's expertise. And so I think it's also the humility of the lawyer, almost even more important than the willingness of a social worker to kind of open the door. It's the humility of the lawyer to understand the roles and the objectives of each particular role. And that curbside consult can establish that confidence, not only from the clinician, but also from the social worker. And that curbside consult can be, you know, multifactorial. So I think what you said, Margaret, was so important about not only kind of streamlining the process, but defining the expertise and then recognizing the power of that collaboration, because the lawyer can increase the opportunity for advocacy, information, and from whatever tack that Keegan's going to talk about as to what the lawyer does next by virtue of that initial collaboration with the social worker. And I have to say, in all the years and all the places that we've worked, The idea at the end of the day is that the social workers and the lawyers become an incredibly powerful team as part of that healthcare team. And that's where the clinician then becomes part of that unique interdisciplinary collaborative. But once the social worker and the lawyer form that understanding of the roles and the power of that collaboration, then that partnership really starts to take off.
Yeah, I think that's exactly right. I have always thought of social workers as professional colleagues. Absolutely. So we hinted that there's next steps potentially, right? Some legal services stop with advice, and that's fine. When we move into conversations about metrics and evaluation, one of the things that we'll point out is that we do value that on the legal side, and we have a kind of a mechanism for thinking through counsel and advice, even if nothing else is provided, and even if it's negative advice. One thing I often have to point out to young lawyers even is even if your answer is no, that's no case, you're still applying law to facts to get to that conclusion, right? It's still just because you can't go further doesn't mean that you didn't successfully counsel or advise someone. So what does come next? Let's think through that. What else is it that a lawyer who's going to be more involved might do? And then let's loop back around to this conversation about how other folks are involved. So can we go, if we could go to the next slide. One, I think, of the most common things that people understand about the work of lawyers is that once you've done that intake, once you've provided that initial bit of counsel and advice, then you may provide representation, right? So this is going beyond advice, but also to provide some kind of action on behalf of the patient, right? And there's also going to be a third party involved. These are opportunities to think not just about the action that the lawyer is taking, but also how, consistent with kind of demands in health policy, we close the loop, right? What information is it that is useful to provide back to the healthcare team if the lawyer is taking action by themselves in order to close out that referral? I think the other theme that I'm hearing today is one that really excites me, frankly, is that some of these activities may occur together. So I'm going to give you an example, and I'm going to continue to lift up social work. One of my former staff attorneys had an elderly patient whose children, one child in particular, was taking actions that were counter to what the elderly patient wanted, including actually trying to evict the granddaughter from the elderly person's home. And so there's all kinds of legal issues wrapped up in eviction, of course. That's going to go to court. But the family dynamics here, that's really complicated to navigate. There's almost an element of choosing sides. And so this attorney partnered with a social worker to say, let's approach this as a family. Let's get you professional expert assistance with navigating the familial aspects of this, even as the lawyer is going to add their tool to this toolkit by helping to resolve this issue that's now in justice court. So that's one example of how representation doesn't necessarily even have to be siloed, right? There's certainly value when it is, but it can also be a collective where we're putting different skill sets alongside each other's. Yes, family systems are. So let's, I'm going to point out facilitated referral, and then Kenya, I'm going to come to you to see if you have another example. Facilitated referrals are the idea that of a lawyer who doesn't have the expertise to handle the issue, or doesn't have the capacity. Could be any number of reasons that we might do a facilitated referral, right? This is a type of warm handoff that leverages the fact that public interest lawyers, MLP lawyers, tend to be pretty daggone sophisticated at understanding the community-based organizations at navigating the social sector in their local area. And we can use that to create the types of referrals for patients that are more meaningful, more effective than just giving them a phone number and telling them to call the folks down the street. I say that with some deliberation because I think there's a lot of that going on right now in healthcare in terms of screening for health-related social needs. So this is an opportunity, in my mind, for the MLP attorney to use their own network and their own expertise and their understanding of the lay of the landscape to make referrals that are effective. So those can take time as well. 30 minutes to 2 hours. We compare that with legal representation, 4 to 80 hours. I would note that the facilitated referral, that the time difference there doesn't mean that that representation won't happen. So that time still may be built in, but it may be a cost in terms of human resources and the finances to support them that is borne by another entity. So with that bit of introduction into how at least my perception of the ways that lawyers may think about these services, Kenya, do you have an example? And I think I'm loving this theme of highlighting the ways that other healthcare team members fit into the legal work.
Thank you so much. Can everybody hear me okay?
Mm-hmm.
Oh, all right, good, wonderful. Yes, the example that I gave was the super helpfulness, and I just cannot even begin to put a price tag on how helpful social workers and case managers are when dealing with the different issues that clients need our assistance with, particularly in the Social Security realm. We do a lot of Social Security disability cases, and oftentimes our clients are they're always generally they're experiencing some very challenging situations, and a lot of the the forms we need completed, the paperwork that needs to be submitted, all of the things that are just really tedious and sometimes are very challenging for our clients. The social workers and case managers are right there and able to provide all of that information and support. So I am of the strong opinion that this would be virtually impossible if we didn't have case managers and social workers there to work as partners with us in providing legal care for our clients. And I wanted to make one note about the facilitated referral. That is also so invaluable because while it is wonderful that some legal aid organizations may have resources in every area of law under the sun, not all legal aid law firms have those resources. So to be able to have those relationships with your fellow legal aid law firms in your area and the ability to refer cases to them is also invaluable in both ways. You give a little, you get a little. So it's very helpful for them to be able to take some of these cases where you don't have the expertise, and also it's very rewarding when you can do the same thing for your colleagues. And I find that is really what works best, and it not only helps us as the law firm, but it really helps our clients.
Yeah, absolutely. Bethany, did you want to jump in?
Yeah, hearing from everyone so far, Kenya, Margaret, Sharon, I also think about the importance of a social worker, but, if a healthcare entity or legal services providers entity doesn't have a social worker, where else might you be able to find one? Or, is there a county public health resource, right, that you might be able to expand and extend the partnership to include, so that you can integrate them into your screening, referrals, and intervention MLP approach. So I'll just throw out an example. In Rhode Island, folks may have heard the presentations from this team that has managed to actually partner with a public defender's office. It's a medical public defender partnership. And that's where the social worker was. That social worker was actually at the public defender's office, and that's the individual who would then help to screen the defendants for healthcare and civil legal need to be able to then refer over to the clinic side of the MLP equation to receive those referrals and provide more robust, comprehensive services that ultimately, down the line should reduce recidivism rates and improve health outcomes. So, the social worker can be placed at various settings. Even in that example, they also had CHWs that were involved on the clinic side. So as we continue with the conversation, just know that even though you may not have that people resource on hand within your organization, they may actually sit on the partnering organization side of the equation. Thanks, Keegan.
Yeah, no, absolutely. Sorry, I was kind of checking the chat as well. If we could for just a second, I want to note that I obviously really value the relationship between an MLP lawyer and a social worker. But as Bethany points out, not everyone has that. There may be ways around it. And that we should also be thinking about other members of the healthcare team as well, like CHWs. I think they are an incredibly powerful component, not just of the healthcare team, but also the legal team. They tend to have a skill set that looks very much like a legal assistant's skill set. And that's an opportunity for training and for multiplying capacity and doing kind of double work from their efforts. Kenya, you also mentioned like disability cases, for instance, right? These are very heavily medical, quite potentially if they're physical health. If they're mental health, you may well have your clinical social workers who are your relevant providers. But the evidence base for those cases, for potentially for a SNAP case, even for food stamps, right? If you're trying to talk about like work requirements or something, for many immigration applications, right? There's lots and lots and lots of legal issues that are facilitated by a close relationship with providers of all types, right? Such as your mental health workers, your clinical social workers, but also your physicians, your advanced practice nurses, your physician assistants, folks who are seeing patients or generating that evidence base. So what are the opportunities to think about the legal representation as lifting up that work? How might the clinician think about the ways that they document that empower patients to be able to move through these systems more seamlessly, right? There's lots of interactivity and an opportunity, I think, in thinking through what an MLP lawyer brings to the healthcare table. All right, let's look at the next set of ideas. These are focused around the ways that MLPs serve whole populations, right? So we were just thinking about individual patients. It's very consistent with the idea of the attorney-client relationship, which tends to be about the individual. But what about when we're thinking about whole patient populations? In healthcare, we have this concept of population health, right? This way of taking a larger population and segmenting it into something smaller. But working beyond the individual. So we see at least a couple of different ways that MLPs and MLP lawyers in particular can get involved, and the ways that the healthcare model broadly can leverage that legal expertise. One is collaborative patient trainings, right? So we talked before about bidirectional professional trainings that are about helping a healthcare provider understand the ways that law may intersect with a particular set of medical needs, or that are about providing a medical context or behavioral health context for the lawyer when they're working with a specific patient population. But we've also hinted that one of the things that MLP attorneys do is provide patient-facing trainings, right? These do tend to be interdisciplinary. They don't have to be, but they can be. They may also integrate a legal clinic. So we have this double use of the word clinic in this space. For you non-lawyers, a clinic, when a lawyer uses it, can mean a couple of different things. It can mean in the academic setting, the experiential learning, right, as opposed to didactic learning. It can also mean in a community, a health center setting, The idea of bringing in a cadre of attorneys, perhaps attorneys from the community, they're doing pro bono work, and providing services to patients all at once, in an individualized manner, but simultaneously, right? So that may follow, here's a training on this thing. Now you all get to go work with an individual lawyer and go execute that will, for instance. So these are really important for building legal literacy for patients. They're really great for multiplying capacity. They are amazing opportunities for bringing in pro bono attorneys from the community who may have, they can commit to 4 hours on a Saturday afternoon, but have a full-time job and couldn't do the MLP work altogether. There's a significant amount of time that's involved, right? It takes a lot of time to plan the training, to create materials for the training, to recruit patients to attend the training, and then to do any necessary follow-up. So let me go ahead and talk about it. Jay's going to give us an example. Actually, let me pause. Jay, why don't you give us an example of an interdisciplinary patient-facing training?
Yeah, thank you, Keegan. One of the I think ideas to practice moments in our medical legal partnership came when one of my colleagues who had previously been a core legal service attorney at a traditional legal aid office brought over the idea of expanding what we now call utility clinics, which were geared toward individuals in the community. And this is a pediatric MLP, so there was a kind of a special relationship between the connection between utility service and children's health outcomes. But the idea of the education, training, and intervention model of individuals who were at risk for losing utility service, whether it be through arrears or through a failure to comply or to maintain a program that allowed for a reduction in arrears or whatever it might have been. And so these really appropriately timed trainings for staff. So it really, again, it goes through the gamut of all the different interventions that Keegan has been articulating. So from training to the staff about what the basics on the laws of utility protection, utility shutoff protection, and recourse for clients/patients have, to the curbside consult for someone who may be facing or faced in a utility shutoff, to the outward opportunity to have one of these utility clinics, which are educative experiences for the patient population, but also bring in the lawyers that Keegan was just talking about on a pro bono basis, and bring in this incredibly powerful community-based group of advocates and community-based organizations and the utility companies to work on literally 100 or more individuals who were either going to face or were facing utility shutoff issues. And the idea here was this interdisciplinary opportunity to focus on the health benefits, the food security issues that were screened at the same time by lawyers, social workers, and other community partners, and the utility companies all at one time. So it became an identification process for the individuals within the healthcare setting and the partners of the MLP, and then the MLP, the L side, working with its partners to provide really a kind of a workforce of individuals to look at the utility shutoff issues, which again are complicated and I'm sure very varied in every state, but it's the opportunity to immediately provide that kind of sudden and then the long-term potential intervention with follow-up and evaluation, et cetera. And the other thing I just want to add one more thing is from practice to policy, this led to a legislative opportunity to change policy for newborns. And the idea that a newborn could not be returned to a house without utilities, period. Meaning that utility shutoff had to be restored, or there could be no utility shutoff within the first 2 years of life, like in opportunities that exist in Massachusetts and Rhode Island. So we kind of borrowed from those two jurisdictions. The bottom line here is that this is a incredibly powerful opportunity to look at the patient-based trainings and in collaboration with the workforce of the medical, clinical, and other social work side that combined in this pretty powerful opportunity. Then that blossomed into other clinical sites with which we weren't even partnered. So again, it has the opportunity to be pretty powerful, but also immediately effective.
That is amazing. Such powerful impact at multiple levels, right? And in my mind, that's just really the beauty of MLP is the ability to move from patients to policy. So if anyone has any other examples or can think about this in terms of, as Bethany points out, health literacy or an education clinic, we'd love to hear them. Diana, looks like you have your hand up. Does this connect for you? Are you, let's see.
You should be able to speak now, Diana. You're unmuted. Go ahead and give it a try. Diana,
We'll give you, oh yeah.
Chat, let us know if you are trying to talk in Zoom, technology. Let us know, Diana, if you can hear us in the chat, because we definitely can't hear you on our end.
Can you hear me now?
Oh, yes.
Perfect. Hi.
Okay. I've been a healthcare provider for 50 years and still am. And I have two scenarios that I'd like to throw out there. I mean, I think this is something that's going to have to be for the healthcare industry and for patient safety. And unfortunately, both times I've dealt with these situations, there's been nothing. First, a 91-year-old elderly female, very limited mobility. The hospice facility where we live opened up a primary care at home track. It was wonderful. And several patients, I think, were enrolled. They were just really, really good. My mom was very happy with the service. And I thought, this is one less thing I have to, drag her out to do. And then one day, just out of the blue, we get a letter that they have discontinued this service and we'll need to find a new provider. And they didn't put a list of providers in there. So I thought, well, now what do we do? I called, and basically it resulted in the providers or the places they were referring people to weren't accessible. And when I asked about this, their staff even said, well, yeah, we have had a lot of patients say that to us. My question is, so what are patients supposed to do? There was a time this would have been considered, I believe, abandonment of your patient, but there was nothing done. It was just dropped. So there was no offer of a social work, can we find you? Can we help? I, as a caregiver, could do this, but there were many that couldn't. So I thought, is this how we're going to, perpetuate healthcare? And we got a large aging population. But like I say, they didn't offer anything to, as far as I know, to help any of the patients that were put in this position. So now you got elderly patients, they have no provider, and we got to start all over.
Yeah, thank you for that. That's an excellent example, I think, of an opportunity for intervention that is collaborative, right? That works on meeting those immediate acute needs, but also thinks about big picture systemically. There's something wrong here, right? As you point out, this is almost tantamount to this concept we have in healthcare of abandonment of a patient. I think we have that on the legal side as well, right? It's the idea that you've just kind of given up mid race. Yeah, I think that's an incredible opportunity for interprofessional advocacy.
The other has to do with family dynamics. Elderly gentleman in the eastern part, rural area of our state, who is in his 80s and, declining, has glaucoma. He had two children. He had a daughter and a son. The daughter passed away with breast cancer about a month ago. The son, who was being treated for an illness and was scheduled to go back to have a further surgical procedure, was sent home, and I'm not sure, either with a trach or a feeding tube. Irregardless, was sent home. No actual home care to monitor this, and suffocates in the night, 24 hours before the sister passes away. When the coroner got there, the reason we know this is he took one look and he said, this has to go for a autopsy. This wasn't just something that happened, it was a problem. So now we got an elderly man with no children, caregiver, wife's already deceased, and 2 grandchildren who are opposed to each other. And I'm thinking, how do you help? There was where do these people go? So CHWs is what I'm going to reach out to and see about that. So CHWs are going to increase with what they're doing and how they're going to be doing things. Where's their support system? Because this is going to be a very difficult legal situation in getting this patient transitioned to the right place and right level of care. And who's the one that's going to guide this or lead it,
Yeah. So thank you for that, Diana. I think you raised some really important points and opportunities for MLPs, right? To the topic of today's conversation, to think about specific opportunities for intervention. I want to make sure that we're respectful of everyone's time and that we are able to get through all of the service types and really have an opportunity to continue to learn from each other, from these really powerful stories. So I want to look at another opportunity that we see from MLP services, and that's actually the shared medical appointment, or also known as a group visit. So we go back just one more. I want to say just a word about this, and then we'll keep moving forward so that we finish on time. Shared medical appointments are, for our legal and academic friends, group medical visits, if you will, right? Instead of seeing one patient at a time, the healthcare provider will see multiple patients. I think in the tradition of behavioral health work, we've had group visits for a very long time, but we also see those deployed for medical visits. So prenatal care, for instance, provided as group sessions for every pregnant person who's going to deliver in the same month, right? Those prenatal visits, and if you've had a prenatal visit, if you're low risk, they tend to be pretty repetitive. So instead of having a nurse midwife or an OB-GYN see each patient for 15 minutes at a time and check blood work and whatnot and keep repeating themselves, what if we take 8 patients and we put them in a 2-hour block, and now we'll do blood pressure once, and we have so much other time created for other opportunities to address the kinds of questions that come up during those visits anyway. Maybe it's IPV if it's prenatal care. We see shared medical appointments also for well child checks for kiddos who are kind of typically developing. So that's an opportunity for intervention. I'm sure many of you are familiar with the Cincinnati study that came out fairly recently, where having a lawyer as part of the care team for a healthy newborn reduced hospital admissions by 38%, right? Incredible opportunities when we partner even for healthy patients, and sometimes those are provided by shared medical appointments. The other one I would point out that we've hinted at here is chronic conditions. So integrated pain management teams, for instance, are an upstream approach to the opioid epidemic. And that's an opportunity as well for the MLP attorney to jump in and to build legal awareness for patients as well as for healthcare teams. So the amount of time involved in that will depend on the length of the visit, but it's a novel opportunity, I think, to really integrate that legal expertise at the population level. That also invites us to consider next institutional practices within healthcare. We've highlighted two here. One is the Complex Care Case Conference. So these are often multi-professional conferences that are focused on one or two or three, usually it's not very many, individual patients who have complex needs. These may include behavioral health challenges. So again, we're talking about the clinical social workers being brought in addition to the physicians or nurse practitioners or et cetera. But it's also an opportunity to embed your MLP attorney, right? The amount of time involved, of course, depends on, is that an hour-long conference or is it a 30-minute conference? Is it a 2-hour conference? And then what the follow-up is afterward. But this is an opportunity to leverage legal expertise with the patient treatment team who has boots on the ground. Similarly, another opportunity, another way to think about what staffing is needed for your MLP is to think through what kinds of committees and task forces and work groups exist on the healthcare institutional side that maybe would benefit from the structural expertise that an MLP lawyer brings to bear. One example I would give is of a clinic who had an institutional policy of not prescribing benzodiazepines, right? And these are anxiety meds and similar to patients who have been arrested. And I'm guessing if I ask the third of you who are lawyers what the problem with that is, you are all going to go, wait, what? This misunderstands something about the arrest process and what it actually says about that person, right? But the healthcare team, that's like the criminal system and the way people interact with law enforcement, that's not something they've been trained in or necessarily know. So it never occurs to them to bring to consider that. So, right. So when we're thinking about the structural expertise and the benefits that MLP brings to the delivery of care, I think it's really important to not forget about institutions as kind of creating a type of law that the lawyer can be a really powerful advocate for. And of course, that in terms of calculating time is going to depend. If you have a weekly meeting or bi-weekly meeting, then that's easy time to calculate. But you also would want to include time for research or other options or responses, et cetera.
Can I jump in for 30 seconds here?
Yes, please.
So what Kika was just talking about, these two opportunities are what also make the MLP so unique. And Kenya, you brought up the idea of being in the room, if you will, and having that expertise, but also having your colleagues at the ready for, you know, a handoff for the other areas for which you may not be a specialist. But this is where the MLP attorney has to be a generalist and a specialist at the same time. And the beauty of this isn't about the, you know, kind of traditional numbers that the legal services attorney is, you know, bound by a certain number of cases per month or year, or whatever it might be. That's dynamic still may be in place, but it's the opportunity to forge these new, and these would be very unique circumstances within the confines of existing structures in the hospital setting or in the clinical setting or in the health center setting. So there are these existing opportunities and structures and foundations. But for example, what we were able to do at the outset was to start a what it's labeled here as a complex case conference, but we called it an interdisciplinary case conference, which primarily focused on behavioral health challenges for children and young adults. And that crossed over into child welfare, juvenile justice, and all the SDOH issues that a population base that the clinical folks were seeing all the time, but primarily focusing on behavioral health challenges, which is obviously a extraordinarily acute one for all of you who work in the community with adolescents and young adults. The point I'm trying to make is that in order to borrow the expertise of your colleagues, this is a great opportunity to bring them in, along with folks within the clinical setting who may have very specific expertise, but not be part of your day-to-day interactions. So it's a really good opportunity to increase the breadth of the exposure, the knowledge, and that interdisciplinary process. And it became an absolute must for the folks who are training for the residency program of a particular hospital to attend these conferences, because they were the folks that were seeing these kids, these young adults in the emergency department and on the floors. And then again, it turns into how is the hospital, how is the clinic, how is the health center dealing with, for example, the issue that Keegan just brought up. In one particular circumstance, it was young adults who had grown into the age of majority, but yet may have had a potential intellectual disability or were part of the child welfare system. And the clinical folks were not recognizing their independent right to make healthcare decisions. So the opportunity to serve and to gain the confidence of the administrative, legal, and clinical folks within the institution can also change the practice and policy, which has a direct impact on patient care. So the breadth of the opportunities is only as significant as the creativity of the lawyer and the champion social worker, the champion physician leader, the champion clinical leader, the home health worker, the folks in legal, whomever it might be that's part of that group.
Thank you. So well said, Jay, right? The MLP attorney's job is to advocate for patients, and that's not always a role that is quite expressly defined. So last set here is of systems, right? We talk in MLP routinely about moving from patients to policy, right? The idea that we take those individual experiences and we multiply them into change, because one of the things that MLP brings to bear on health advocacy is a lawyer's expertise in the levers of social change. That can occur at two levels. We just hinted at ways that it can occur at the clinic level, right? Thinking about our institutional policies, procedures, and pathways can be through regular work groups or committees. But it can also be about inviting the MLP attorney to recommend other changes, or maybe that as a result of the of a referral, the MLP attorney notes, you know what, healthcare entity, you're accidentally creating a disparity here. In the interest of time, I'm going to give an example that I suspect more than one of our audience members could give. Maybe your healthcare entity has a policy against engaging in a certain type of advocacy, disability forms or workman's comp or something. Having that attorney on board may multiply capacity in a way that increases understanding and that makes it more possible to address those issues. So that might be the kind of opportunity to create clinic level change. How long that's going to take will always depend. If you're talking about creating template letters for the EHR to make it easier for clinicians to help someone who has a medical condition not have their utilities turned off, for instance, or someone who, in the early days of the pandemic, we saw lots of eviction protections that required clinical expertise. Well, those can be template letters that the MLP legal team can create. They can be embedded in the EHR. It makes it much easier for everyone. So those are the kinds of topics that we're also thinking about, and how much time will vary dramatically. Similar are policy level changes, right? Going to and making changes in the law at the state level or even at the federal level is something that we've seen from MLPs. One example that comes to mind is alignment of federal housing requirements around lead levels. And this came from a single patient and then a set of patients, right? To say, look, the recommendation, the requirement under the housing law doesn't match up with medical best practice. So how do we work together? How do we collaborate to just change the whole law in a way that benefits the entire population? This is, I think I would say to our healthcare friends, really the heart of where legal aid lives. It's what it was created to do. So I really want to lift that up. We have only a few minutes left, so I want to turn now to how we put all of this together, right? Because that's the question we're trying to answer. It's not just what are the opportunities for interprofessional staffing that's consistent with MLP, that recognizes that we're not talking about creating referral networks, right? We're not talking about legal teams as unidirectional providers, but rather as an integrated care team. But nonetheless, we recognize that we have to be able to value time in order to set our contracts. And again, we'll have more conversation about budgeting. So let's look at a couple models. The first model really emphasizes, perfect, thank you, legal patient engagement, right? That attorney-client relationship, very focused on advice and representation and even warm handoffs. Does not exclude population level efforts like curbside consults, right? Where you're helping the doctor, for instance, understand an issue better. Doesn't exclude trainings, doesn't exclude clinic level change projects, but really emphasizes that one lawyer, which is what we're looking at, one full-time lawyer, can have a schedule that's arranged around legal assessment. So again, we're maximizing legal representation of patients as an example here. We could contrast that with the second model, which again, 1.0 FTE MLP lawyer. This one really emphasizes the role of the MLP attorney as a member of the care team and emphasizes those professional relationships. So less interaction with specific patients, with individual patients, and more interaction with the other professional providers, right? Those curbside consults or water cooler moments, right? Routinizing those, creating trainings regularly in a way that benefits, that's really focused on either the professionals or the patients, or maybe both together. And finally, clinic change, right? How does the institution of healthcare practice in ways that leverage structural expertise? The third example here is is emphasizing policy change, right? Those state and federal changes, the places where there is something in law itself at the macro level that is creating the health disparities that you're seeing in your patients. Oftentimes, to know what that is, you actually have to bring the lawyer on board. Very briefly, I'll give an example of a clinic that had seen disparities amongst its pregnant migrant worker population for 20 years. They had immense documentation. Literally, a first-year lawyer took one look at this and said, oh, well, there's actually this thing in the law at the state level that means that they can't take off work for the right, like, and was able to fix it. So sometimes it doesn't even it's just about bringing that additional perspective into the room. And so you can really emphasize that approach as well. So here's another example of a reasonable expectation of work for a 1.0 FTE MLP lawyer. These are just models. They are in the toolkit. They can be changed, but they give you a jumping off place for thinking through what reasonable expectations are. And by setting expectations, you can really help to ensure success of your partnership. So a couple of closing thoughts, and then we'll wrap things up for today. We've given you some summaries of ways to think about maximizing the impact of the MLP approach, maximizing the capacity of the legal team in particular, in terms of thinking about staffing, perhaps narrowing to focus areas that are in alignment with the SDOH that you mean to address, like we talked about last time. Being realistic about your capacity assessment and creating the kind of model like the three that I just showed you. And also recognizing that as you get started, it takes time to build trust. It takes time to build relationships, right? And that first year may look different than things do over time. It may be that you start out thinking you're very focused, for instance, on individual patient engagement, but that the real power that your MLP feels is in policy change, right? So there are adaptations over time. the bottom line here, I think we can go to the next slide, is that we really want to invite you to continue to engage with us and with each other, to think about the ways that the P in MLP, right, that the partnership is happening, and to use that to build your staffing decisions and requirements. So one more word that I want to say is who should be making those decisions, or who can be powerful allies in making those decisions, as we think about the ways that attorneys incorporate legal expertise into healthcare, as we think next about the ways that clinicians incorporate legal expertise into healthcare. Having a team, and including in your staffing decisions a team of champions, can be instrumental. So very often MLPs will remember the legal champion, right? Having an attorney who is able to serve as a bridge between the legal services organization and the healthcare, the medical team, to help both understand those connections between health and law is common. But recognizing also that you need champions from across the healthcare spectrum. You need that case management champion, like we've talked about over the last hour and a half, but you also need a clinical champion, someone who understands clinical workflows and can help navigate those day-to-day experiences and opportunities. And I think best practice also is to have an administrative champion. One of the most powerful things that I ever accidentally did in an MLP was find a CEO who thought this was important. So an administrative champion, someone who has that big picture view of the healthcare's priority, is a very, very powerful ally, and should be a part of your champions team as well. So with that, Bethany, I'm going to turn it back over to you.
Thank you so much, Keegan. I really like and appreciate that you ended on that note about finding that administrative champion, both on the legal and the healthcare side. And we've certainly found champions, speaking of those who are on the administrative side, at the federal level. So there are federal agencies that also, right, as well as your local agencies in the states and the cities and counties, where there are MLP champions. So don't forget them. Speaking of, the Health Center program in HRSA and the various champions, they want to hear from folks if they have a specific request about the mechanics or the technicalities of Health Center funding in particular, and how to integrate medical legal partnership appropriately. So on the screen, you'll see that we are directing people, perhaps as a reminder, to HRSA's help desk, because they want to be able to be helpful in advancing medical legal partnership at health centers. So in addition to our Health Center MLP toolkit, which is plugged in the chat, don't forget that health centers have the ability to submit questions directly to the Bureau of Primary Health Care using the contact form. But we're also here to help. So again, I'm Bethany Hamilton, the National Center for Medical Legal Partnership, been joined by Keegan Warren and Jay Siklick, our primary faculty today. And I want to acknowledge that the audience, you are also resources. We've designed this webinar series to ensure that everyone has the ability to share their insights, their experiences, and ask questions, because that helps the entire field learn about where we can go together to advance this movement. Again, this webinar series, and sorry, let me also take a moment to just sincerely thank Keegan, Jay, and the audience for sharing, participating, and teaching each other. So I want to thank you, Keegan and Jay, for helping us lead this webinar series. Again, this webinar series has many more parts that are coming soon. We're running it from February through June of this year, and you can actually take a look at all of the topics and the registration links and the resources and archives on the Medical Legal Partnership website. There's a specific page dedicated to it. This hyperlink will be included in the slide deck that's shared and posted on our website. And then finally, join us on March 14th to continue the conversation where we'll focus on how will we staff? How will we actually staff now that we've considered the SDOH needs, as well as the broader staffing that's in MLP? How will we actually staff the legal services component? do we do this as a direct hire sort of model, or do we work with an outside entity and build a contract to carry out our MLP practices? So on March 14th, I believe Jay, our lead faculty, will be facilitating that conversation. We can auto-register everyone if you let us know that that's what you want done by filling out our evaluation. We have a question in there to find out if you want to be auto-registered for the future event. But please do take a moment to fill out our evaluation link in SurveyMonkey and let us know if today's presentation was effective and how we can do better to offer you content that you need. With that, we're going to close out today's webinar. Again, I want to thank everyone for joining us and hope to see you again on March 14th. Thanks, everyone.